My name is Anna Tabet, and today we'll be reviewing the AUDIT screening tool. This is the alcohol use disorder identification test that is generally used in the primary care clinic to reduce alcohol misuse. Let me give you some background on alcoholism. According to the Center for Disease Control and Prevention, there were 88,000 deaths each year due to alcohol use in a 2010 report. It is still the third leading cause of death in the United States, and there have been many social issues that have been derived as a use of alcohol abuse, such as homelessness. There's also a history of increase in illegal activity if you become if you use alcohol and you misuse it. And there also have been mental issues that have evolved because of alcoholism. Or in some cases, some patients that have a history of depression or sadness or anxiety tend to use alcohol to self medicate. Symptoms of alcoholism, which include cirrhosis of the liver, esophageal varices, hypertension, and cardiac problems. Actually, these are just to mention a few. There are many comorbidities that are associated as a result of alcoholism. Excessive alcohol consumption in the United States has an estimated cost of $223.5 billion just on excessive alcohol consumption alone. So, some consequences of alcoholism involve loss from work, increased healthcare expenses due to increased sicknesses and illnesses and disabilities that are that have been developing in the body as a use of alcohol. There is also legal issues. If they catch somebody with a DWI, this can lead to numerous fees, loss of licensure, and excessive legal fees to retain an attorney to help you in this bind. There's also been deaths reported because of DUIs, disabilities, people become physically hurt and paralyzed. Due to impaired driving, there's also an increase in motor vehicle costs due to accidents or running into a mailbox or running into a garage. There have been a lot of increased fees due to this. States Preventative Task Force, screening adults, adolescents, and pregnant women should occur in the primary care provider's clinic. Why is that? Because one tends to establish a rapport with their provider and one learns to trust their provider. If there is no trust, then the patient should look for another provider. With this screening tool, high risk behaviors of alcohol misuse can be identified. And harmful behaviors can be addressed before harmful behaviors develop, such as alcohol addiction. So, why utilize the audit? It's a simple method of screening for excessive drinking and to assist in brief assessments. Identify excessive drinking as the cause of the presenting illness when the patient comes for a visit. The audit also provides a framework for interventions to help high risk drinkers reduce or cease alcohol consumption. The audit also helps to identify alcohol dependence and some specific consequences of harmful drinking. With the audit screening tool, designed for healthcare practitioners and a range of healthcare settings, but with suitable instructions so that it can be self-administered or used by a non-health professional. Screening for alcohol consumption among patients in a primary care carries many benefits. It gives one the opportunity to get to know their patients, to identify low risks and high risk patients, and to educate patients about the consequences of alcohol use. Screening also offers the opportunity for practitioners to take preventative measures that have been proven effective in reducing alcohol related risk. The audit is low cost. It is standard in multiple countries in different languages. It identifies harmful alcohol use and possible addiction. It's fast, flexible, and designed for primary health care clinics. And what's most important is its emphasis is on recent alcohol use, unlike other screening tools that focus on chronic use. Barriers in the primary care setting by the providers to use this tool. First of all, research dictates that there is a minimal number of screenings done in primary care settings. Most providers state that this is due to a lack of time. They don't have enough time in the day to do the screening tool, per research. Some felt that this screening may jeopardize the patient and provider relationship. Patient and provider trust each other, and when a provider asks them personal questions, some patients may be insulted, or at least in certain cultures or in different countries. So the provider chooses not to ask these questions. Another barrier is that follow up is rarely done. The individuals that are trained to perform these screenings rarely do follow ups. This needs to change. We need to catch these patients before they become alcohol addicted or other hazardous behaviors. Screening tool developed by the World Health Organization, where again it assesses consumption, drinking behaviors, and alcohol related problems. This is a link for your reading pleasure that you can shows you the difference between the cage and the audit. As you can see in this example, there are 10 questions that a patient answers. Sometimes the screener asks the questions, and also the patient self administers these questions. So take a look at the 10 questions. They're very personal. For example, how often do you drink? Do you have a drink containing alcohol? All the way to how often do you have 6 or more drinks on one occasion? If you look at the bottom, this is a key and a guide used to tell you the different scores and at what point you should intervene. In one research study by Zavar, Harari, Ali Moradi, and Kosarvi, there were 70 individuals in this study with alcohol use disorder and 70 non-alcoholic individuals for the control group. The Persian audit was completed for all participants. Again, it has been translated in many languages, so it is the same audit 10. An explanatory factor analysis was used to construct validity and reliability of the audit. The correlation of the T retest results was statistically significant, p equals 0.020. By using the RLC curve at the cuff point of 8, a specificity and sensitivity of 89% and 99% was achieved for the test, and the accuracy of the area under the curve was achieved to be 99%, or p less than 0.001. This is quite significant. The cutoff value of 8 in audit questionnaire was specified as the best cutoff point. Control subjects obtained significantly lower mean scores compared to the alcohol subjects with a p less than 0.001. This simply means there is less than a 1 in a 1,000 chance of the stated result being incorrect based on observed error. It means that the result was statistically significant at the probability levels. Research, given the acceptable reliability and validity of the Persian audit and its high sensitivity and specificity, it can also be used as an effective instrument for identification of alcohol use disorder for high risky drinkers and early detection of alcohol addiction. There have been several studies. I will talk about a few of them. A study by Orr, Macaulay, Graham, and McCord in 2015 conducted a pilot study that was conducted in 3 local authority areas in Scotland. They used the audit screening tool, and they considered this tool the gold standard for alcohol screening. The author felt that the staff needed to understand how follow-up data and how to educate the staff. This seems like a universal theme. The individual who is screening the patient needs to have a full grasp and understanding of the screening tool, of each question, and how to follow up with the patient. The U.S. Preventative Service Task Force, in a study by Tan, Hungerford, Denny, and McKnight in 2018, has recommended that primary care providers screen all adults and implement some brief counseling. The author recommended that providers should utilize suitable screening tools to allow providers to better identify patients with alcohol misuse behaviors so that proper education would be implemented. Again, we need to catch these risky behaviors as they're starting to prevent hazardous problems to the patient and long-term problems as well as socio-economical problems and perhaps even legal problems, not to mention health problems. Lee, Jung, and Choi research was conducted to explore the abbreviated versions of the audit. There's a new version called the Screening Tool for At-Risk Drinking, or the STAD, for the young and middle-aged adults. The author felt that it was important to understand the various types of audit screening tools. I prefer the Audit 10 with the 10 questions. Why? Because I think it is a more comprehensive tool. It is fast, it is easy, and patients do to respond to this type of questionnaire. And Markham and Dwar focused on validating screening tools such as the Audit C for at-risk drinking in Australia. This was interesting because in Australia, there was a heavy influence on social cultural factors such as the stigma of alcohol dependence. Therefore, and also that the patient's history was unreliable, and these providers felt there was a threat to patient-provider relationship. The Australians value their trust with the patient, and they don't want to lose that sense of trust. So they prefer not to ask these questions in an effort to preserve their relationship and not to offend the patient. And finally, in Romero, Perula, Leiva, Fernandez, and Parras, this study evaluated the knowledge, attitudes, and practices of providers, nurses, and physicians in a primary care clinic in Spain. Again, universally, there were problems in the screener fully understanding how to screen a patient and how to conduct follow ups. These gaps have to be caught, they have to be prevented so that we can improve healthier outcomes for our patients. We plan to train the medical assistant. The medical assistant must be properly educated per protocol to administer the screening. In my opinion, upon taking the patient's vital signs, when they are gathering the chief complaint from the patient and they are taking the blood pressure, the temperature, the respirations, etc., their pulse, this is the time to conduct your screening. This provides or preserves the provider-patient relationship and saves the physician or the provider time. Again, medical assistants must follow up with the patient. This is the loophole. This is where we get caught, is that people are forgetting to follow up with these patients. What are the implications? The implication is that the audit is the hallmark for identifying high-risk patients for misuse of alcohol. There are many mental health overlapping symptoms that may be identified as well. When a patient is withdrawing from alcohol, they may experience anxiety, depression, and sadness. So, as providers, we must become very familiar to understanding our patients to find out were they were they feeling anxious, sadness, and depression prior to the alcohol, or is it after the alcohol? So, spending time with our patients, and this gives us time to have a trusting relationship, then we can really identify what is overlapping and what are the true symptoms of the patient. This also allows the PMHNP to elicit a dynamic relationship with the patient by asking them, perhaps maybe in the beginning, once every 6 weeks, or it can progress to once every 3 months, depending on how the patient is doing. To conclude, alcoholism is prevalent in the US, with 88,000 deaths have been reported by the CDC in a 2010 report. It's still the third leading cause of death in the US and also contributes to many health problems, as well as social issues, financial issues, and legal problems. The United States Preventative Task Force has recommended that alcohol screening should be performed in the primary care clinic settings. There have been many problems in the primary care setting with alcohol screenings, and the patients are not screened. Physicians and providers are concerned about the time that they are allowed to screen a patient. They're also concerned about jeopardizing the relationship between provider and patient, and they're also concerned that follow up is not being conducted properly, again, putting the patient at high risk. The audit screening could identify high risk behaviors and could save the patient's health, and could help the patient at risk by providing education and interventions to prevent the alcohol misuse and to prevent the inception of an addiction. Thank you. I hope you enjoyed my presentation.